All right, I think we can probably get started. My name is Tom Harmon. I'm the Executive Director of Development for the Department of Neurology, and specifically today, host for this webinar with our leaders in the Corinne Goldsmith Dickinson Center for Multiple Sclerosis here at Mount Sinai. We're very privileged to have so many of our faculty leaders here to share with us not only what has been presented recently at some global conferences, but also what's new here at our own MS Center at Mount Sinai. So to kick us off, I want to introduce Dr. Fred Lublin. He's the Saunders Family Professor of Neurology and Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis. Dr. Lublin.
Thanks, Tom, and thank you all for joining us this afternoon. My colleagues and I are going to spend a little time updating you, as Tom had mentioned, on both the newest information that we've received from recent meetings, including the ECTRIMS meetings, the European MS research meeting that was held in Amsterdam last month, but also a lot of what's new going on here at Mount Sinai. So work in MS and related diseases continues to move at a rapid pace. There's many areas of interest that we're pursuing, and I'm just going to touch on a few, and my colleagues will fill you on even more. One of the recent events that's happened and was detailed some in Amsterdam last month and is going to be covered in greater detail at an upcoming meeting in February in this country is the role of Epstein-Barr virus, EBV virus, the virus of mononucleosis and multiple sclerosis. And there's been some recent work suggesting a very close association between infection with EBV and then subsequent development of multiple sclerosis. This is still at the stage of an association, but the data are getting stronger and stronger that EBV is playing some role, not necessarily as a direct infection, but possibly as an environmental cofactor, as something that may be necessary, but not necessarily sufficient for developing multiple sclerosis, because EBV infection in the general adult population is up to about 90%. And most people get the infection early on. It may or may not express itself. It could be mono, it could be other things. So more work is going on with that, and it'll likely lead to some therapeutic trials, which will be of interest to see. Another area that's been expanding and getting very interesting is genetics. So we've always known that there's been a genetic role to multiple sclerosis. And we've always known that genetics alone don't answer the question, that there's something in the environment that we'll hear more about that also plays a role in who develops multiple sclerosis and who doesn't. But there's some recent genetic work suggesting that there are specific genes that control the severity of the disease. And like 4 have been recently identified. One of them is associated with also determining whether someone gets multiple sclerosis or not. But the other 3 were separate, meaning that one's genetic makeup not only may determine the risk of developing multiple sclerosis, but the risk of having more or less severe disease. And so we're not at that level yet, but at some point in the future, we may well be in a position to do genetic screening. Another issue I wanted to mention was the issue of aging. So our MS population is getting older. Even when you look at cohorts of patients, the average age of individuals who are already diagnosed as prevalent multiple sclerosis has been inching up into the late 40s, early 50s now, even though the average age at onset still was in the early 30s. This has provided some interesting challenges to us, including trying to develop a better understanding of how our therapies work in individuals who are older, because older age group often is not tested in the therapies, but also dealing with the comorbidities, the other disorders that occur as people age, whether they be vascular or metabolic or arthritic and all these other things. So it's become a part of our thinking, and it impacts how we view, for example, the patients refer into the wellness clinic, and you'll hear more about that. We've also continued our interest in progressive MS. Progressive MS is the form of MS where you have the most impairment and the form that we're least well able to treat. And so there is a large international collaboration which is studying multiple aspects of progressive MS, how it develops, when it develops, who it develops in, because it's not inevitable and it doesn't develop in everybody, and then how to develop better therapies to address that. And the last one comment is the growing area of MS-related diseases like neuromyelitis optica, NMO, and what's now called MOGAD, MOG-associated disease, which differ from multiple sclerosis in that they're driven by an antibody. You can measure a titer in the blood, and that helps you in diagnosing them and to some degree treating them. But we are now in the position where we now have approved therapies for NMO, and we're developing more and more information on this idea of MOGAD and who to treat and how to treat and how to better recognize that. So those are some of the things that crossed my mind to discuss with you. I'm now going to turn it over to our center's medical director, Dr. Aaron Miller.
Thanks, Fred, and my welcome to everybody. So I'm going to highlight very quickly some of the things that were of interest to us, particularly clinically, at the recent ECTRIMS meeting in Amsterdam. So a lot of the buzz these days in the MS therapeutics world relate to a group of drugs called BTK inhibitors. These are drugs that impact the activation of B cells. You may know that we have a number of drugs that kill B cells that are highly effective in relapsing remitting MS and may be effective, at least modestly, in progressive forms of the disease. The BTK inhibitors potentially have some advantages over those monoclonal antibodies because they get into the brain well, and they appear to have some impact on what are called microglial cells, which are felt to be involved in the degenerative stages of progressive MS. So these drugs have extensive development programs. Several companies have them, and they are already in phase 3 trials. At Mount Sinai, we're involved in in 2 of the major phase 3 trials in both secondary and primary progressive MS with one of these drugs called tolebrutinib. I want to mention a study called DISCO MS, which we've been very actively involved in at Sinai. This was a trial in which a very selective group of patients over the age of 55 were randomly assigned to come off their drug or to remain on the drug. It was a complicated design. I don't have time to go into it in detail. The goal was to try to demonstrate that it was not inferior to take people off drug. The trial did not prove that, but it also did not clearly demonstrate that it was inferior. So my own view is that selected patients may still be considered for coming off drug, but they have to understand in more detail the outcome of that trial. For many years, we've defined a syndrome that we refer to as the radiologically isolated syndrome. This refers to people who have never had a symptom to suggest multiple sclerosis, but stuck their heads into an MRI machine and lo and behold came out with a number of lesions that look like MS. And so we've been grappling with what to do with people like that over the years. In general, most MS neurologists have customarily not treated those patients initially. We know that now from natural history studies that about a third of those people will develop MS, meaning they'll have clinical symptoms within about 5 years, and about 50% will develop symptoms within 10 years. In a study headed by a neurologist named Darren Okuda, patients with the radiologically isolated syndrome were randomly assigned to take a particular MS drug called Tecfidera or to take placebo. And it turned out, and this was no surprise, I think, to just about anybody, because we actually think that RIS is probably MS. But to no surprise, there was a substantial reduction, about 80% reduction in the development of clinical relapses in the people that took Tecfidera. Whether or not one should treat these patients based on these data is a subject we can maybe get into further in the question and answer session. We've known for years that vitamin D, low levels of vitamin D have been associated with a greater likelihood of developing MS, and if you have MS, with a worse course of MS. But the question, so that we've had the custom of trying to get patients' vitamin D levels well into the normal range. A question that has not been answered, however, is, do we actually make a difference by giving vitamin D to people? And it turns out, in a study that's been going on for a number of years, the results were finally presented at ECTRIMS. And in this particular study, it did not make any difference whether you added relatively high doses of vitamin D or very low doses of vitamin D to the clinical course of the MS. Turning to NMO spectrum disorder that Fred alluded to in his remarks. For those who may not know, NMOSD was formerly thought to be a variant of MS. So we now know it's a completely distinct disease mediated by a particular antibody against a protein called aquaporin 4. And it can be a very devastating disease with significant visual and neurological disability accumulating because of the consequences of severe attacks. There are currently 3 specific drugs approved for the treatment of NMOSD by the FDA. One of those drugs is a drug that inhibits a group of proteins called complement, which are involved in the disease process. That drug, which is called eculizumab, is very effective, but it has an unwieldy schedule of infusions requiring intravenous infusions every 2 weeks. In a trial presented at ECTRIMS, a modified version of that chemical class called ravulizumab was tested and was extremely effective, producing something like a 96% reduction in relapses. And this drug has the advantage of needing to be given only every 8 weeks instead of every 2 weeks, which is a huge advantage. And finally, I'd like to very briefly mention a study that I've been very actively involved in of something called depot-glutarimer acetate. Many of you are familiar with Copaxone or glutarimer acetate, which has been extremely widely used for more than a quarter of a century, but requires injections every 3 times a week by the patient. In this study, the results of which have been reported only by press release, but the compound was highlighted at ECTRIMS in another context. This trial had a positive result comparable to what was seen with the commercially available Copaxone preparations. And this is the accomplishment of this trial, I think, was quite remarkable because it's probably the only randomized phase 3 trial ever to survive a pandemic and a war, because nearly half of the patients in the trial were in the Ukraine. So with that, I'll quit and turn this over to Alana and be happy to talk about questions later on.
Thank you, Dr. Miller. Thank you all so much for being here today. So what I'd like to do is actually to highlight one particular presentation at ECTRIMS and then use that to tell you a little bit about some of the work that we're doing here now. So this is a presentation by our colleague, Dr. Jim Samowski, who I'm sure a lot of people are familiar with. He is a neuropsychologist who focuses entirely on MS and is doing really interesting work here, a lot of which is related to the concept of reserve and how we can prevent disability in people who are living with MS going forward. So the presentation at ECTRIMS, I would say, was definitely one of the more provocative presentations at ECTRIMS, which made a lot of people very excited because the central thesis really was to challenge our ideas about cognition in the field of MS. So the point that Dr. Samowski wanted to make is that our ideas about how cognition is impacted in MS are based on a time when the disease looked very different than the way it looks now. Fortunately, we are now able to have all of these effective treatments and we're really able to keep people healthy, and cognitive issues are still a problem, but they're a problem in a different way. And so he looked back at a paper that was published back in 2004 at a time when most of the participants hadn't really been on MS treatments. And if they had been on treatments that we would now consider kind of in our, more modest or lower efficacy bucket of treatments, compared to what we have available now. And at that time, the conclusion from that paper was that the central problem in MS was processing speed. However, what we observed in our patients, clinically during our visits in the office, but also really when we developed our neuropsychology clinic over the last few years, was that that's not what people were telling us. When we asked people were telling us, the problems I have are with word finding, with language. I can't pull a name out as quickly as I'd like to, or when I'm giving a presentation, I'm having trouble, stumbling over words. It wasn't really a processing speed problem, or people say I'm having problems with my memory. And so Dr. Samowski was able to formally study this by comparing that cohort from 2004 to our own cohort from our neuropsychology clinic. And he looked at 562 people who had come through our neuropsychology clinic recently and looked at their data on tests related to processing speed, as well as other tests that are related to things like memory and language. And what he found was that the results were very different compared to those from 2004, and that people really don't have a major problem with processing speed as we suspected, because this is what people are telling us. But he was actually able to show this in a formal way. And so this really challenges the ideas that we have about cognition in MS, and I think allows us to move forward, because a lot of the studies that have been done trying to improve people's cognition in MS, most of the studies really have not been successful. And there have been a lot of questions as to why. But I think one of the reasons is that we've kind of been barking up the wrong tree and going after something that's not actually the problem, or not telling the whole story. So that's why this presentation was very exciting. It also, I think, is extremely helpful in terms of moving forward from our standpoint, because it helps us in terms of the research that we're focusing on here at Sinai. As I mentioned, Dr. Samowski leads a cohort called the Radiums cohort, which is Reserve Against Disability in Early MS, which we enrolled back in 2016, 2017. And we are now starting the year 6 follow-ups on all of those people who so kindly volunteered to be part of the study. And we're just learning so much, and we're going to continue learning so much, I think, going forward, not only about their cognition, but also about their physical capabilities, and so many other things about their daily lives that I think is going to be really helpful to all people living with MS. Our neuropsychology clinic that we started back in 2018 has also turned into a really incredible resource for research. I think all the clinicians really love the program. It gives us so much, it's just so informative when we see patients in the office and we have that report in front of us and we can see how our patients answered all these different questionnaires. It helps us identify problems with cognition, but also with mood, and so many other things that we really are able to intervene on. And so that's really exciting for us. And as I mentioned, from a research standpoint, it's just an absolutely wonderful resource, and we're doing a lot with it. I know a lot of people have asked questions and are interested about diet. We actually just very recently published a study using the same exact cohort. We had 563 who were eligible from their baseline visit, and we found a very nice correlation between people's dietary habits and their level of MS-related disability. And that was after we controlled for all kinds of things that are usually problematic in dietary studies. So we were able to control for things like not only age and sex, which are kind of traditional variables, but also socioeconomic status, which is a big issue when you think about diet, body mass index, so it's not only weight, smoking, and all kinds of medical comorbidities. And that association was still persistent. So that brings us to how we address these issues, the cognitive issues that Dr. Samowski has been talking about, but also more broadly, how do we keep people healthy? How do we allow people to live their best lives? And that's where our wellness program comes in. So I think a lot of people are familiar with the program, which was launched a little over 2 years ago at this point, and has really been a wonderful resource for us. So for those unfamiliar with the program, when people start as a new patient in the wellness program, they have a visit with their nurse practitioner, the dietitian, the physical therapist, and the social worker all in one. And then follow-ups are kind of on an as-needed basis. We've also introduced a behavioral health specialist. We've been very excited to add Dr. Jordan Anderson to our faculty recently. And so we are actually able to help people make these really positive changes for their health. Going forward, we'd like to be able to show that formally from a research standpoint. And so we've got some work designed to try to help us do that. Our biggest limitation for the wellness program at this point, and again, these are the interventions that we think are going to make a big difference for people going forward. Our biggest limitation is just resources. So it's a very expensive program to run. We're not able to bill the visits as of now for the dietitian, the PT, and the social worker. And so those are services we think are critically important for our patients, but that require, constant influx of funding to be able to maintain the program. So I really do thank all of you for your generosity in helping us support it. And I'm looking forward to the research that we'll be able to do, I think, going forward to really show that these interventions really matter for people. With that, I will hand it over to Dr. Erin Beck.
Thanks, Alana. So I am one of the MS neurologists, and I see patients in the MS clinic, but I spend most of my time doing research. And so I'll tell you a little bit about the research that we're doing in my lab and how it connects with some of the things that the others have been speaking about today. So my research focuses on using advanced MRI techniques and a more powerful MRI scanner with a more powerful magnet called a 7 Tesla MRI to understand more about MS. And so we know that MRI is incredibly important, of course, in making decisions and diagnosing MS and determining whether someone is responding to treatment. But there's still a lot of things that MRI doesn't tell us, in particular, whether someone will go on to have progressive MS and whether they will, how they will do over time. And so what we've been doing is trying to develop and answer some of those questions. And I'm going to just show one slide that shows just a couple examples of the kind of pictures that we get from the 7 Tesla MRI and some of the things that we can use it to see. So these are two different image types that we get from a single scan, and this is actually the same person. This is a person with MS who we scanned at Mount Sinai a couple months ago. One of the things that we can see is we can tell the difference between a lesion that's fully demyelinated, and those are the ones that are circled in red here, and lesions that are partially remyelinated, meaning they've undergone at least some repair. So these bright lesions, the brightness here suggests that these are fully demyelinated, whereas the darker gray lesions are ones that have been partly repaired. And now that we can see this, we can ask questions like, what are the factors that predict whether a lesion will be repaired or not? And also, once we have potential drugs that might promote remyelination, we can use the MRI as an outcome to see whether we can turn a lesion from one of these red lesions to one of these blue lesions. The 7 Tesla MRI also allows us to see lesions in parts of the brain that have been really inaccessible. So one of those regions is the cortex, which is the outer layer of the brain. And we know from pathology studies going back over 100 years that these lesions in the cortex are really common in MS. But we've had a hard time seeing them on MRI until recently. But now that we can see them, we've been able to tell that having lesions in the cortex is associated with disability and progressive disease. And in fact, seems to predict the presence of cortical lesions, predicts whether someone will get worse over the next few years in a way that white matter lesion burden may not. And so this is really exciting. And then finally, one of the other markers I'm pointing out here is what I'm pointing to with these pink arrows is the central vein sign. So MS lesions form around a vein, and you can see that vein here on this type of image with these black line going through the bright lesion. And the exciting thing about this is that this appears to be pretty specific to MS, meaning lesions in MS have this central vein sign, but lesions that may form in the brain for other reasons do not have the central vein sign. And so this may help us tackle what has been a very long-standing problem, which is that it can be difficult from an MRI to know whether the spots we see in the brain are really from MS or something else, which delays diagnosis sometimes or leads to misdiagnosis of MS and starting treatment for something that isn't actually there. And so there are multi-center clinical trials going on right now to look at that and to see whether the use of the central vein sign could help us with diagnosis. And some of these markers are associated again with progressive MS, and so could be used in clinical trials in the future. And we're also looking to tie back to what Dr. Katz-Sand was mentioning about language difficulties in people with MS. We did find in a previous study that lesions in the cortex tend to occur in regions of the brain that are important for language. And so what we're going back now is doing testing for language deficits, and that's in work in collaboration with Dr. Samowski to see whether lesions in those regions are associated with language deficits and might explain some of the deficits that we see in our patients. And then finally, what we are also doing is combining these advanced MRI methods with immunologic studies in blood and spinal fluid to try to understand the mechanisms, the immunologic mechanisms underlying the things that we see on the MRI, which we hope will allow us to target these things with medications, either ones that are already in existence or ones being developed now. I will stop there.
Awesome. Thank you so much, Dr. Beck. While we have you highlighted, so the 7 Tesla MRI, that's a much more powerful MRI than patients get clinically, correct?
Yep, that's right.
By what magnitude?
So the field strength, the normal MRIs that people can get just clinically are either 1.5 Tesla or 3 Tesla. We prefer people get 3 Tesla MRIs because it gives us better pictures. So the field strength is, more than double what we get with the 3 Tesla MRI. And what that allows us to do is basically it's like looking kind of with a zoom lens. We get to see more detail and we get more signal from every spot in the brain. And so we get a much clearer, crisper picture that allows us to see finer details of the brain.
Excellent. We did get a couple of questions ahead of time related to this, and I will remind folks too that you can put some questions in the Q&A function if you have them. But we did receive quite a few from folks ahead of time, and one question was, how safe are these 7 Tesla MRI for the processes that you do? Are there any downsides to using them?
Yeah, so we think that they're quite safe. 7 Tesla MRIs have been used in people for about 10 years now. We haven't really identified any health risks to using them. We have to certainly screen people much more carefully for any sort of metal implants in the body. Things that are safe at 3 Tesla are not always safe at 7 Tesla. But as long as we screen our patients very carefully, which of course we do, then there's really no increased risk that we're aware of. It is a little bit of a smaller kind of bore is what we call it, the kind of tube that you go into. So sometimes people may be a bit more claustrophobic or a little bit more uncomfortable, but in terms of real safety risks, we don't think there are any.
Excellent. And I see someone had asked about the dietary study, Dr. Katz-Sand, that you had mentioned. And we also received quite a few questions related to some of that diet work. Any particular advances that you would want to point to, specifically what kinds of diet choices seem to make the bigger impact?
Sure. So I think what we're learning is that it's probably not going to turn out to be one particular thing. So the work that we've done up until this point has pointed us away from it being one particular nutrient or one particular food or food group. So I don't think the answer is going to be, well, if you just eliminate meat or you just eliminate dairy. I think the idea and what we're learning is that it's probably the overall pattern that's important. we haven't been able to specifically show until now in a rigorous way that it's one particular pattern for sure is, the best diet for MS. We may end up learning that things actually are slightly different for different people. But I think we do have enough evidence, and it's all observational at this point. We do need to get toward very serious, clinical trials, which is what we're trying to do. That's a big goal of ours here over the next few years. But for now, I think we do have enough evidence to recommend following certain overall principles. So I'm very fortunate to be part of the National MS Society's Wellness Research Working Group. And that's made up of MS researchers from around the country who have similar interests. And people are testing out different diets. We have colleagues in the group who are testing out ketogenic diets and intermittent fasting and very low fat diets and paleo diets. And what we were able to do was create a consensus of a few recommendations that we think make sense to recommend now, even in the absence of really rigorous evidence for one particular pattern. And those are available on the National MS Society website. But just to summarize, the recommendations are that you prepare as much of your food at home as possible. That if you're going to eat grains, that they should be whole grains rather than refined grains as much as possible. That you should incorporate, fresh fruits and vegetables as much as possible, and frozen are also a good option, which leads to the last recommendation, which is to stay away from ultra processed foods. So things that come in a bag or a box are to be avoided, as much as you can. It's not to say that as I mentioned, like frozen fruits and vegetables we consider to be fine, and there are certain foods that are pre-prepared but that we would consider minimally processed. It's really the highly processed stuff that we'd like people to stay away from as much as possible. That seems to be some of the driving factors that are associated with things that lead to poorer outcomes in MS and general health as well.
Gotcha. And while we have you, question about exercise as well. How would you characterize what's the evidence base for certain types of exercises at this point for folks with MS?
The exercise literature is actually a little further along than we are in terms of diet. I think in part because there's a very fantastic dedicated group of like exercise physiologists and things in MS who've been doing this research for years. There was a paper that was published about 2 years ago that summarizes recommendations for both physical activity and for exercise in people with MS. And those two things are separate. So physical activity kind of refers to your activity level in a given day. So that might be, walking, chasing after your kids or, things like that, getting up from your desk, stuff like that. Whereas exercise really refers to a dedicated exercise program where we're talking about huffing and puffing and sweating. And so there are some recommendations for each of those categories. Overall, I tend to do this as a more personalized approach. I think it's very important to consider what someone is able to do and to make recommendations based on that. And that's what we try to do in our wellness program, is to have every person meet with the physical therapist, to have an assessment to see where they are. The recommendations for somebody who is able to run are going to be very different from the recommendations for someone who uses a walker to walk, right, in terms of exercise. The overall goals are the same. We think that some form of aerobic exercise is really good for MS. It helps not only with functional status, but we think exercise has also important benefits in terms of neuroplasticity and repair. That's a very active area for research right now. So aerobic exercise is important. Weight-bearing exercise is also really important, not only for MS, but for general health in terms of maintaining bone health as we age. And so we like to have kind of an individualized approach to an exercise regimen for people.
Which speaks to why something like the wellness program is so important, so that can be that personalized plan.
Yeah, absolutely.
Dr. Lovell, coming back to you, you had talked about the new Epstein-Barr virus, some of the research going on in that association. Do you feel like some of these approaches look particularly promising? And if so, in what ways?
It's hard to know just yet. And I think there's some research protocols that are going to start up. We live with Epstein-Barr. It lives in us. at least in 90% of us. It lives in our lymphocytes and the B cells. And so it's not clear yet what its role is in triggering MS or in response to MS, and whether trying to eliminate the virus from the body will make a difference or not. And we don't have the technique to do that just yet. So there's a lot more to learn about it. And I just don't think we have a therapeutic approach yet.
But you're relatively optimistic that this could provide some new insights?
Well, I think it will provide some very interesting insights. I must say, having gray hair, we've been down the virus route before many times in the past 40 years. But I must say this one has the most interesting data supporting it.
And while we're on you, and you mentioned viruses, we got a number of questions ahead of time related to COVID prevention strategies around particular types of immune suppressant therapies that folks are on. I know that you've been working with our own Immunology Institute here at Mount Sinai to kind of not only help address some of these current questions, but as you think about another pandemic in the future, what's that work looking like?
So COVID kept us very busy from day one. First, it was dealing with the infection in our patients who we've altered their immune systems to benefit their MS, but that doesn't benefit a viral infection. Fortunately, the vast majority of our patients who did get sick did quite well with COVID. And we were working, as you mentioned, with our other colleagues in autoimmune diseases and with the Immune Institute to look at this. And then the second challenge we had was the issue around vaccinations. The first was to make sure all of our patients understood the importance of being vaccinated, especially when you're taking immunomodulating medications. And then second, our determinations of how our medications were affecting the ability of the vaccine to actually do its job, to work, because some of our medications limited that, which just made it even more important to make sure you got the vaccine schedule. And we had to figure out, timing between infusions and dosing of the medication and when the vaccine was best given. And so we're still seeing some COVID in the community, but we're not seeing severe disease in general. And for any of my colleagues, they differ, but overall, we felt our population actually survived this quite nicely. And it has taught us a lot of lessons for the next pandemic.
Excellent. Thank you, Dr. Lublin. Dr. Miller, coming back to you, you had talked about this new line of BTK inhibitor medications. Do you anticipate all of these sort of being similar to each other? Will they have a lot of differences between them? What's the future of this particular therapy look like?
Well, so there are at least 5 BTK inhibitors that are already in clinical trials. A couple in phase 3 trials, several others still in earlier stage trials. They have differences in their biochemical properties and perhaps in their ability to penetrate into the central nervous system. I tend to be an empiricist. I think the proof of the pudding is in what comes out in the clinical trials. So my guess is that they're going to probably behave fairly similarly, but I could be wrong. So we'll see. Unfortunately, we still have probably about 3 years before the first of the phase 3 trials is completed. You're on.
I am on mute. While we have you, you had mentioned the study that was somewhat indeterminate about taking some patients off their medications, and you seem to intimate that there were some criteria that might apply to making that kind of decision. How do you go about potentially recommending that a patient come off their medications?
Yeah, well, first of all, the audience needs to recognize that this was a highly select group of patients who went into the study. They were over 55. They'd been on medicine for at least 5 years, at least 2 years on the same medicine. They hadn't had any clinical attacks or any new MRI lesions, well, no attacks for 5 years and no new MRI lesions for at least 3 years. So this is a population of people doing very, very well. So what the study showed, and the reason it didn't reach its non-inferiority endpoint, was because more patients in the group that came off of the drugs had MRI lesions. Now, there were almost no relapses. There were 260 patients in this trial, and there were a total of 4 relapses over 2 years of follow-up in these 260 patients. So the likelihood that somebody's going to have a relapse, whether or not they stay on the drugs, is very small. If you look at the MRI data, in the group that came off drug, I think 16 patients out of roughly 130 had at least one new MRI lesion, but the majority of those who had any new MRI lesions had only 1 or 2 small lesions. So my view in talking to patients who are in this category is, look, if you're somebody who really hates taking the medicine, whatever medicine you're on, then you're probably going to be pretty safe coming off if we continue close surveillance with MRIs. If you're somebody who, could either take or leave the medicine, that don't really care, then it's probably a little safer to stay on. So it's a conversation, and it's a matter of, I think, one's personal tolerance for low levels of risk.
No, perfect. Thank you, Dr. Miller. I see a question in the Q&A, and we had a couple of questions early on as well, maybe for Dr. Lublin and or Dr. Beck, but a lot of questions around any new progress in myelin repair, nerve damage repair. I think that's probably the $500 million question is, can we actually start getting some of these lesions to repair themselves in some way or through therapy?
Erin, you want to start?
Sure. So as you mentioned, Tom, there's been a lot of work on this and a couple of trials. Unfortunately, so far, they've mainly been unsuccessful. And I think what's still yet to be determined is how much that's because those medications don't actually work versus if we don't have the right way to measure their success. And I think it's very difficult to do that clinically because because it's hard to measure the improvement in symptoms in a way that is consistent across patients with all different symptoms. And I think the development of biomarkers, whether they be MRI markers or blood markers, will be potentially really helpful in this regard, because it means that we can increase our power to actually detect efficacy of these medications. But unfortunately, at this point, we don't have anything that we can bring to the clinic to help people repair their lesions.
There are some approaches that are in early phase testing, and Dr. Beck alluded to what they can do with the MRI scan. There's also some work being done with something called a PET scan. The two main approaches right now experimentally are with molecules that can either enhance myelination or remyelination, or inhibit the inhibitors of remyelination, which does occur in MS. And the other is cellular replacement therapies, like mesenchymal stem cells. But they're still all of them in very early phases. And as Dr. Beck alluded to, we're still learning how best to test them.
We did get one question specifically around stem cell research.
So there's 2 types of stem cell research. One is autologous hematogenous stem cell, which is really bone marrow transplant. And that is similar to an immunotherapy in that it's used for turning off disease activity. And we're doing a study here, which Dr. Miller is leading, part of a national study supported out of NIH to look at that possibility. And he can discuss that further. The second approach is the cellular replacement, which is things like mesenchymal stem cells or neurally directed mesenchymal stem cells, where you're not trying to alter the course of the disease, but you're trying to produce improvement. And again, those are in early phase studies. We're hopeful to see them move forward, but they have a ways to go. Erin, you want to just say something about BEAT?
Sure. So we know that autologous hematopoietic stem cell transplantation works for people with active relapsing remitting MS. The problem has been that in the past, the treatment was dangerous. Sorry, let's keep slipping now. The treatment was dangerous. And what you're doing with this form of treatment is you're taking all your risk up front, basically, because what you do when you give these cells is you have to abolish the person's original immune system. So they're terribly immunosuppressed for a period of time at risk for infection. So you're taking that risk up front. And then once you replace them with the stem cells, then they don't have that risk for infection. So they may have a very long lasting benefit from the treatment. What the trial that we're involved in is comparing people with very active disease to either get the stem cell transplantation or take one of our most highly efficacious therapies. And we'll see over a 6-year follow-up period whether a group that gets stem cell transplants does any better than the group that takes highly efficacious therapy.
Dr. Katsan, coming back to you, a lot of folks were asking specific questions around emotional health and cognitive health. You mentioned Dr. Samowski's work in the cognitive space. Any specific guidelines or evidence-based treatments approaches that you're recommending to patients?
Yeah, so those are two, huge issues, and they are interrelated. So a lot of the time, for example, when someone comes to us and is reporting, worsening cognition, that can actually be related to issues with mood. So those things are definitely related to each other. And I think in the wellness program, we try to really address all of these issues in a holistic fashion, as opposed to piecemeal. I think the biggest thing that we've done, I mentioned before that we recently hired Dr. Jordan Anderson, who some people may know. She was one of our neuropsychology fellows and has now joined our faculty. And she's still doing assessments in our neuropsychology clinic. However, she is actually just about now starting a practice. And she is doing psychotherapy for our patients, both doing health behavior counseling for the wellness program, as well as doing more general psychotherapy. So we've been waiting on her getting credentialed with insurances, but I think, that's a great place to start for a lot of people is with psychotherapy for mood issues. And again, you can address some of the cognitive issues in there as well. It has to be a personalized approach. And I think psychotherapy provides that. It's been an issue that we've struggled with for a long time. We often recommend psychotherapy to our patients, but it can be difficult for people to access, to find a provider who takes their insurance and things like that. So I think this is going to be a very nice resource for us. We do use traditional medications, and for depression, which is particularly prevalent in people with MS. As well. And I think the way we're able to achieve the most success is by combining those two. And so that's something I usually will discuss. And again, it's a very personalized decision based on the symptoms that the person is reporting. But a combined approach is the most evidence-based approach, I would say, that we have, but it has to be very personalized depending on the particular patient.
Thank you. I guess we could, unless there's any other folks want to ask a question in the Q&A, we just have a couple more that we had ahead of time. Sort of a bit of a lightning round, maybe whoever wants to take some of these. Oral versus injectable medications. Are injectables ever going to disappear and be totally replaced by oral medications completely?
Let's give that to Aaron, since they did the most recent study of an injectable.
I really think people need to look at the comparative efficacy and comparative safety of drugs rather than think so much about the route of administration. Obviously, there are very few people that like to take injections. One of our most efficacious therapies now is given by injection, but it's only once a month, as opposed to the older injectable medicines, which were not only less effective, but which required usually injections at least once a week, and more often than not, more frequently. So I don't think it's a matter of injections being replaced by oral therapies. If we get an oral therapy that's highly, highly effective, it will probably be widely used compared to injections and infusions. The oral medicines we currently have available, for the most part, I would consider to be in the moderate efficacy category. So some of our intravenous infusions and the once a month injection are more effective on average.
Thank you, Dr. Miller. What are some of the latest treatments for secondary progressive multiple sclerosis?
Alana?
So progressive MS is the area that I think we need to improve the most as a field. Progressive MS is getting a lot of attention from a research standpoint right now. We talked a little bit earlier about the Sanofi trials. Dr. Miller had mentioned about BTK inhibitors. I think that's the thing that's furthest along, in these clinical trials now, and we're participating there. That's, I think, really where we are. There are a lot of other things coming down the pipeline, a lot of other ideas, but I would say that's the one that's the furthest along. It can be also very difficult for our patients because most of the times in these clinical trials, the upper age limit for participation is 55 or 60. And most of our progressive patient population is older than those ages. And so that can be very frustrating in terms of people thinking about participation in trials. But that's where we are right now. Currently approved therapies, siponimod as an S1P modulator is approved in secondary progressive MS. We often will use ocrelizumab, B-cell therapy, which has an approval in progressive MS. The study was done in primary progressive MS, but we extrapolate that because that's what we have. So we've made some progress in the last few years, but it's not nearly enough. So this is the huge research focus for the field for the next few years. And it's actually the dietary study that I alluded to earlier that we have designed, which is an interventional clinical trial, is focused entirely on people with progressive MS and trying to see whether we can use diet as an adjunct treatment to help slow neurodegeneration in people with progressive MS.
So that might even be a good segue into a new audience question. Has there been any news or insights on the role of gut health, microbiome in regards to MS, diet, leaky gut, probiotics, prebiotics? Dr. Katz-Sander, you've looked at this quite a bit.
Yeah, so this ties into all the things that we've been talking about. We actually attended a lecture this morning that was given by our very own Dr. Stephanie Tanku. And she talked about a study that she is starting right now that we all started recruiting for, which we're excited about. She was awarded a very prestigious Doris Duke Career Development Award to work on this project. And so in this project, she's going to be randomly assigning people who have just been diagnosed before they're on MS therapies to either take or not take an oral antibiotic for 30 days. It's an antibiotic that's not absorbed. It basically stays, it only decreases the bacterial load in the gut. It doesn't get absorbed into the peripheral circulation, so it doesn't affect other spots in the body, which can be a major issue with other antibiotics. But the idea here is to be able to manipulate the gut microbiota, and it's not necessarily to make antibiotics into a strategy for an MS treatment, but rather to help us identify bacteria that may be of benefit and that may be producing metabolites that may be anti-inflammatory, for example, or may help protect from neurodegeneration. And so this study, as I mentioned, is just starting now, and we're excited to see where that goes. In terms of developments that have come along recently, there was nothing that was really interesting that was presented at ECTRIMS on this topic. I think we're making kind of slow progress in this area. I think when we first started working on trying to understand gut bacteria and MS, we thought it was going to be more straightforward than it has been. It turns out that every study that comes out, it doesn't necessarily jive with results that have been published before it. So that's been problematic. We've taken it down to a couple of themes at this point, though, and kind of overall concepts. And so we're working through some of those. I can tell you also that for our radium study, the reserve study that I mentioned earlier, we collected stool samples from everyone at year 3, and we are now in the process of analyzing those. And so we're looking forward to being able to hopefully correlate, looking at relative abundance of different types of bacteria and seeing whether those correlate with outcomes, MRI outcomes and clinical outcomes in everyone who's participating in the study. So that's where we're going with that area of research next.
Awesome. Thank you, Dr. Katzand. And before we wrap it up here, Dr. Loveland, any final thoughts, any things you're particularly looking forward to in 2023 in regards to the life of the center?
Well, we're looking to continue and expand our wellness efforts and this sort of holistic approach, a term I use with great caution because it's been bastardized so badly. But in terms of trying to take care of all of these modifiable risk factors that you've heard discussed in terms of diet and exercise and lifestyle and dealing with comorbidities and the other medical things that are going on. And we look forward to seeing the results of some of these clinical trials that are coming down the pipeline. We may get one new approval of another B-cell inhibitor over 2023. I don't know that we'll have any other approvals over that period. But the work on progressive MS is getting more and more attention, and more will be going on with that. And we're going to be learning more about this potential viral issue and how we can address that.
Excellent. Well, thank you all so much for your time. Thank you to our audience for such great questions. Of course, another great thing to look forward to is the fact that the annual MS Center Gala will be in person again next spring. So be on the lookout for that. Today is just happens to be Giving Tuesday. And if you're inspired to support the center in its work, you could point your smartphone up to this code that's on the screen now, particularly things like the wellness program that the faculty have spoken so highly about and we know has been such a tremendous source of support and progress for so many of our patients, to really give them that personalized wellness approach that we've always known would have a positive impact, but the evidence is sort of catching up to what we've kind of known in a common sense way. But thank you, Drs. Loveland, Miller, Katzand, Beck, for your time. And thank you for all of you joining us today. Have a great rest of your year.
Thanks, everyone, for joining us.
Thank you.